Morning. Today we are going to see about concept of screening. So what we have to know about screening, we are going to see about screening and its types, the difference between diagnostic test and screening test, then uses, then what are the criteria that a screening test should have, and what are the characteristics that a screening test should have. So before going to that, so here we are seeing an iceberg phenomenon that we all be knowing. So here it is, tip of the iceberg that we are seeing, and this is the submerged portion. So this is the part where we usually see in our OPD. As a doctor, we sit in OPD and patients are coming. So they are visible part of the community who are having disease, whereas this is submerged portion where we are not going to go into the community and check for misdiagnosed case, undiagnosed case, subclinical case, asymptomatic or pre-symptomatic case, and we also have carriers. So these are the invisible case because we are not going to go into the community and we are not going to check. So for that reason, we are having something called screening test. So what is screening? It is the search for unrecognized disease or defect by means of rapidly applied test, examinations, or other procedures in apparently healthy individuals. So the keywords are, it is done for unrecognized disease, not for the usual recognized disease. It is for unrecognized disease and in apparently healthy individuals. Okay, we are not going to check people who are having symptoms and signs who are coming to OPD. No, this we are going to do in apparently healthy individuals. Okay, who are not seeking any health care, not for people who are coming to health care. So example, we have serological testing for AIDS that we are doing ELISA for AIDS. That is one example. And when the baby is born, we are doing neonatal screening and we are doing premarital screening for syphilis, and also now we are doing genetical disease also. So this we are doing for preventive purposes. So here we are going to see about that difference between screening test and diagnostic test. So what are the difference? Number one, it is done on apparently healthy individual, whereas diagnostic test we are going to do for sick people, whereas screening test we are going to apply in groups, that large population, whereas diagnostic test we are going to diagnose a single patient only. One patient is coming with signs and symptoms, we are going to apply diagnostic test. Then screening test, it is results are arbitrary and final. Suppose we want to do screening for hypertension, so we ourselves we are going to have one cutoff value, that our decided cutoff value is 130/90. So beyond 130/90, whoever is going to come, they are hypertensive. Below that, they are normal people. So this 130/90 is final, then no change will be there. According to that only, we are going to diagnose hypertension. Whereas in diagnostic test, we have signs and symptoms, we have investigation, we have other investigation, other mode of diagnosis also. So we will correlate all these things, then we come to conclusion. So diagnostic test is not final. And since we are going to put more money and more knowledge on diagnostic test, it will be accurate. I mean, it is more accurate, whereas screening has less accuracy. Then screening is based on one criteria only. Whatever criteria that we have found or we have developed, it's based on that one single criteria only. Whereas diagnostic test, it is based on signs, symptoms, lab findings. So we are having so many criteria to have a diagnostic test. and it is more expensive, right? We are going to have more expensive diagnostic equipments, like we have CT, MRI, and also that diagnostic tests that we are going to do also, it might need more money. Whereas screening test we are going to do in a large population, not like unlike diagnostic test, we are not going to do in a single person. Since we are going to apply screening test in a large population, it should be less expensive only. And it is not based on treatment. Screening test, we are not going to screen because of treatment, because it is to pick diseased individual in a community. So our aim is to just pick up the diseased individual. Whereas in diagnostic test, we are using test to pick up the disease and also to give treatment. It is purely based on treatment. Then screening test, the initiatives comes from investigator or agency providing care. So in screening test, we ourselves are going to community and we are going to see the uh, people and we are going to find the disease. Whereas diagnostic test, the initiative comes from patients. They themselves come with complaint, then we are going to diagnose those patients. So these are the basic difference between screening test and diagnostic test. So there is something like concept of lead time. Why we have to know this? Suppose you are a program officer and you need to do screening. What are all the diseases that you do screening? How we will come to know that I have to do screening for this test, and which screening test you will apply? Suppose you want to screen diabetes and you are having 3-4 screen tests in your option. How will you pick this screening test I have to do? To know that, you have to know about concept of lead time. Let us take, this is some disease. So this is the progression of disease. So disease agent comes here. So onset of disease, that is biological disease onset, starts here, and disease is developing, then it is started slowly developing, then at some point we can able to pick the disease. So this point is called first possible point of diagnosis, because before that we cannot able to pick the disease, but here we can able to pick the disease. Then again it is progressing. Then at one point it is going to change from reversible to irreversible form, or it is going to change as a complication. So this point is final critical diagnosis. Then it is again going, it is developing, and suddenly the patient is having complication and he is coming to you and you are diagnosing. So this is the initial time of diagnosing. Okay, this is like natural history of disease only. For example, this is diabetes. The patient is having diagnosis, then he is coming, then it is developing. Then here diabetic retinopathy is going to start. This point he is going to start with diabetic retinopathy. Then he is having vision problem. He is going to come to you, that as a medical officer you are going to see the case. Now you will find that the patient is having diabetes. So here the patient is already having outcome with complication. Suppose if you want to intervene in the first possible point of diagnosis, the progression of the disease will change. How? Instead of going to this side, it is going to come to this side. How? Since we are going to diagnose an early stage, it is not going for any complication. So you are going to bypass all this complication. So the patient will fall into this category. Okay, so there is something called screening time that you are going to see, or you are seeing this here. Screening time is nothing but it is time between first point of diagnosis to final critical diagnosis. So this is screening time. And lead time. What is lead time? it is advantage or it is the gain of advantage between first possible point of diagnosis to the usual time of diagnosis. So what is the use of this? Why we are going to uh, see this, or by introducing screening time, what is the use? And one we have seen is we are totally changing the path of the disease. Another thing is when we are going to subtract this from this, like B from A, we are going to get some value, that is the amount of people who are prevented by introducing screening test. Okay, suppose if you are going to check screening test A, screening test B, screening test C. In A, suppose if we are going to prevent 50,000 people, in screening test B, if we are going to prevent 1 lakh people, and in screening test C, we are going to prevent 20,000 people. Now you have come to know that screening test B is preventing large number of people, that we can find from subtracting B minus A. So if you are a program officer, you will be choosing screening test B for your program. So if you want to introduce screening test for your program to prevent diagnosis, then you will choose screening test B. In that case, I am saying. So lead time, it is the advantage gained by screening. That is the period between diagnosis by early detection and diagnosis by other means. Now we will be seeing about uses of screening. So it is used for case detection. How that we are going to check for unrecognized disease in an apparently healthy individual. By doing screening test, we are going to pick one disease. Next is control of disease and research purposes and educational opportunities. So case detection, just we are going to find the case. It is also known as prescriptive screening. In case detection, it is useful for the people who you are going to screen. Suppose if you are screening a lower socioeconomic status woman with pap smear, if she is having that early stage of cervical cancer, you are going to diagnose that patient and give treatment. So that patient is having benefit when you are finding case detection. Then other examples are in case of pregnancy. If we are going to do screening, like we are going to do hemoglobin, we are going to screen for diabetes, BIH, then RH compatibility. Suppose if we are going to find something coming as positive, we can give treatment for the particular disease. So case detection is helpful in this way. So here you can see that they are doing pap smear. Here they are doing here. So one we have seen case detection. What is the other use? It is something called control of disease. It is also known as prospective screening. So how it is useful? How screening is useful for control? Now, right now we are having COVID pandemic. Suppose we are going to screen, if there is some screening test we have done, and we are going to screen people, and then we can able to control the disease. How? If we are going to screen one patient, and if you find that that patient is having COVID, we are going to isolate that patient. By isolating him, he is not going to spread disease to his surroundings. That way, we can able to control the whole population. So this is one of the use of using screening test. So here they have given other examples like TB, syphilis also. Third is research purpose. How it is useful in research purpose? Because by doing screening, we can able to find the disease. In early stage itself, we are going to find the disease. So we are going to give treatment and we are going to watch the patient. So by just seeing we can able to find the natural history of the disease also. Other things are, if we are going to do screening in a large population, we can able to find prevalence and incidence also. We can able to find incidence also. So in such way, it is useful for research purpose also. Other thing is educational opportunities. We can able to know which disease is public health important disease by doing screening. That we can able to know, and we can concentrate on that particular disease, and we can able to do educate common public, and not only common public, we can educate health professionals also. Another thing is we can make that public awareness. So these are the uses that we have seen. Now we are going to see about what are all the types of screening tests that we have. One is mass screening, then high risk or selective screening, and multi-phasic screening. Other things are also there, like multi-purpose screening that we will see. So mass screening, this is nothing but screening a large population, large group of people for the purpose of detecting disease. Okay, it is offered to all irrespective of the particular risk individuals. We are not going to catch one particular risk individual. We are going to do screening in the whole population. That is, in the group population, we are going to do a particular screening. I mean, a screening for a particular disease that we are going to do. So that is mass screening. Here, there is a lot of logistics that we have to use. So it is not much advisable. Next, we are going to see about high risk or selective screening. In this, we are going to select only the high risk group. Based on the epidemiological research or epidemiological findings that we know, we will be knowing these people are high risk. For example, we can see that low socioeconomic status group women, they are having chances of increased cervical cancer. So this we know, by literature we know these are the people are having increased chances. So we are going to take them as high risk groups, and we are going to do screening test. So by doing that, we can able to find the prevalence of disease. Other thing is, for any STDs, we can able to take high risk group as female sexual workers and lorry drivers. These are the people are, by our research, we are knowing that these are high risk group. So we are going to apply specific test for them. Then we are going to find the amount of disease that they will be having. Then something like multi-phasic screening. It has been defined as the application of 2 or more screening tests in combination to a large number of people at one time to carry out separate screening tests for single disease. So here we are going to do separate screening tests for a single disease. For example, if we want to screen disease A, okay, first we will be having health questionnaire, then we will be doing clinical examination. By health questionnaire, we will arrive at diagnosis. The clinical examination also we do, and we will come with diagnosis. Then we do measurements, then we do investigations, then we go for investigation. So we check all these procedures, then at last we come to one conclusion. So here we are doing screening at health questionnaire time also, then screening at clinical examination, then investigation also. So this is multi-phasic screening. There is something like multi-purpose screening also. In that case, we are going to have an individual, but we will be checking for so many diseases. Like take for example, take pregnant women. In pregnant women, we are going to check for hypertension. We are going to check for diabetes. We are going to check for RH incompatibility. We are going to check for anemia. Single woman, but we are going to do these many tests, and we are going to screen these many various other diseases also. So this is multi-purpose screening. Here it is multi-phasic screening. Okay. But this multi-phasic screening is not recommended because it is one is expensive, it takes so much of time, and the researchers that done in UK and USA also suggest that multiphasic screening has not shown any benefit. Okay, so that is why it is not recommended. So now we are going to see about on what criteria screening test should be picked. Okay, one is the disease to be, we are going to see as two points. One is according to the disease, what are all the criteria they should have. Then according to the test, what are all the criteria they should have. First, when it comes to disease, the disease which we are going to screen, it should be an important public health problem. Like it should be tuberculosis, it should be HIV. So these are the major public health burden we are having right now in India and also in the globe. So these are should be our target. So we should develop screening tests for this only. Then the condition should have recognizable latent or early symptomatic stage. We should able to find the early symptomatic stage or recognizable latent phase. Then only we can apply screening test. Then we should know about the natural history. So when we know the natural history, then only according to that we can able to do screening test also. Then there should be suitable diagnostic test. So whichever screening test, whichever disease we are going to do screening test, we are not going to start with screening test. So we should have suitable diagnostic test to confirm the screening test. Then that screening test should be available easily. The test should be easily available and it should be safe. It should be safe to all individual and it should be easily accessible to the population. Then there should be an agreed policy based on what? Then test findings, the national standards, and to regard who as the patient, who should be the patient. Okay, and the whole process should be a continuing one. And there should be an accepted and established treatment or intervention. So this is which we are going to see. That disease should have established intervention or it should have proper treatment. Then only we can do screening. Otherwise, if we are going to screen for disease which is not having proper treatment, then there is no use. Then the cost also should be less or it should be economically balanced for this screening test which we are going to do. Then according to disease wise that we have already seen. Now we are going to come according to test. The test which we are going to do, what are all the characteristics that that test should have that we are going to see. Number one, it should be simple, it should be easily acceptable, then it should follow acceptability, repeatability, then validity, and according to cost also we are going to see. So first one is simplicity. What is it? The test should be simple to perform and it should be easy to interpret. Any person can able to perform it without any struggle and it should be very easy to interpret also. And where possible, capable of use by paramedics and other person also. So it should be easy for paramedics also to use without the help of physician. Then acceptability. It should be easily acceptable voluntarily by population. General population should come forward and they should have to take. So you should not put any test which is going to give pain or discomfort or embarrassment to that patient. So whatever test you are going to do, it should be very easy to do. So then the people, general population will come and they themselves will take the test and do. There is some first one we have seen simplicity and acceptability. Now we are having something called reliability and validity. Repeatability, reliability both are same. Validity and accuracy both are same. So what is, before seeing about this slide, we will go here. What is repeatability? The test should give consistent result in repeated trials. Okay. the result should be consistent. There should not be a major or big change in the result. For example, here you see, okay, this is a board that here they have thrown arrow. Let us take this as arrow 1, arrow 2, arrow 3, arrow 4, arrow 5, arrow 6, arrow 7. So this is our target actually, but it is not hitting on the target. It is gone somewhere far away, but the number of times you are throwing arrow, the result is consistent. It is only coming in this area. It is giving consistent result. So this is having repeatability. It is not having validity. Why? Because validity is the test must give a true measurement. Okay. So if you see here, this is our target. So whatever the arrow you throw, it should come here only. It should give true measurement. See here. It is every arrow is pointed on the target. So it is having validity. Okay. But here we don't have validity, but here we are having reliability. In this case, we have validity also, reliability also. Why? Each and every arrow having consistent reading. Every arrow is showing on the same place. Even first time when they do, it is hitting on this point. Second time, again, third, fourth, fifth, sixth, every time it is hitting on the same point. So it is giving consistent point, and that point is also, it is near to the true value. So it is having reliability and validity. Here it is not having validity, but it is having reliability. Why? Again, this consistent value, but it is not actual value. So here you are having low validity and low reliability. It is not either hitting near the target area, and it is not concentrated also. So that repeatability, how it will be affected, or what are the factors that it is going to affect the repeatability? One is observational variation, then biological or subject variation, then error related to technical method, the method which we are going to do, what are the error that we are going to do. So according to these three only, this repeatability will vary, or there will be some problem with the repeatability. One is observational variation. How? Intra-observer variation. Variations by a single observer on the same subject at same time. Okay, suppose you are taking BP. Here, this lady is taking BP of this patient. So she is taking reading. Then again, if she is going to take reading of the same patient, there is some variation is coming. So that will be intra-observer variation. Variation by a single observer on the same subject at the same time. This can be minimized by taking averages of several readings. Suppose today at 3 p.m. she is taking one reading. Tomorrow again 3 p.m. she is taking the same reading on the same hand with the same measurement, everything. But there is some differences coming. By doing average, we can able to minimize that error. Then inter-observer variation. Suppose one patient is coming with chest pain. Three people are going to check that X-ray. Okay, and their interpretation is different. So that will be the inter-observer variation. So this can be minimized by standardization of procedure. So if we are having standard protocol, so both will be knowing the same protocol. So the variation can be minimized. Then intensive training of observers. So we have to train the observers according to the protocol that we have, so that they can minimize, making use of 2 or more observers. When more observers are going to come inside, that difference of opinion will going to reduce. So that is how it can be minimized. Then first we have seen observer variation. Now we are going to see biological variation. Observer variation is what doctor or the observer who is going to see the patient, they will be having, doing variations. But biological variation, the people or patient themselves will be having some variation. So there is biological variability associated with many physiological variables. So for example, BP, that we are having white coat hypertension. When a person is going to see doctor, suddenly his BP shoot up. Then if you ask him to wait for 5 minutes, then you take again, then you will be having normal BP. So this variation that you had previously because of the doctor, that is physiological variation, that is biological variation, that is coming from the patient himself. This may be due to changes in the parameter observed, variation in the way the patient perceives their symptoms and answer, and regression to the mean, tendency for values, and extreme to degrade to the mean or average on repeat measurements. Then third thing is errors relating to the technical methods. These variations are inherent in the method. For example, your sphygmomanometer is defective or it is showing error that you have not checked. So how many times you are going to do, the reading will always come wrong. It is not because of the patient or doctor, it is because of the instrument. Okay. So likewise, you are having calibers and faulty reagents that we are going to use. So one is by doctors or observer, other one is by patient himself, other one is by instruments. So these are the three things that will affect your repeatability. Then there is something called accuracy. Okay. The accuracy means that we have seen that whatever the result has come, it should be near to the true value. The test must give a true measurement of the condition or symptoms under investigation. Okay, there are two components that we have to check here. One is sensitivity and specificity. What is sensitivity? It is ability of a test to identify true positive individual, the patients who are actually positive. What is specificity? It is ability of the test to identify true negative individuals, that is patients who are actually negative. Okay. Suppose here you see, here they have given one cross table. It is giving details of glucose tolerance test for detection of diabetes. So here they have put the diagnosis. But here disease present, disease absent. Here they have used some screening test that they have seen here. Screening test positive, screening test negative. This is disease positive, disease negative, screening test positive, screening test negative. So for 10,000 people, this test has been done. So you see here, this is true positive. This is true negative. Why this is true positive? It is accepted positive by disease also, and it is accepted positive by screening test also. And here also it is same. It is accepted negative from both sides. So this is true negative, true positive. Now, what is sensitivity? Sensitivity is to find true positive. How we are going to find true positive? Let us assume this A, always put A, then B here on the right side, and C down D. Once you form this, if you apply A divided by A plus C, that will give into 100, that will give sensitivity. Then true negative, specificity, it gives, let's take the true negative value. For specificity, D divided by B plus D. That will give your specificity. Here in this particular case, you can see that sensitivity is less, specificity is more. A good screening test should have both sensitivity and specificity in a higher side. So here you are having less sensitivity. So the ability of picking true positive is not reliable in this case. Then there is something called positive predictive value or negative predictive value. Okay, just look at this. This test, it has picked 60 people are having diabetes. but among 60, actually 40 only having diabetes. So it is the ability of the test for positive predictive value. It is the ability of the test to pick actual positive case from its own value. Okay, here it is given. Predictive value of positive test indicates probably that a patient with positive test result has, in fact, the disease in question. User. See, here we have 60. This is the total positive cases that we found from our screening test, but actually 40 only 40 is having the actual disease. So among your screened test, how many people are actually having this positive disease? So this is positive predictive value. That is the ability of the test to predict this actual positive from your test value. Same for negativity also. So for positive predictive value, the formula you have to apply is A divided by A plus B into 100. For negative predictive value, it is D divided by C plus D into 100. So when you put this, you can able to get sensitivity, specificity, positive predictive value, negative predictive value. Then there is something called mean. It is the amount of previously unrecognized disease that is diagnosed as a result of screening effect. Okay, it depends on many factors like sensitivity, specificity, and prevalence of disease, and participation of individuals. Okay, so now we have seen about simplicity, acceptability, repeatability, validity. At last, we are having cost. Why cost is useful? I mean, needed because the screening test we are going to apply in a large population. So whatever the actually existed screening test, if we are going to introduce a new screening test, there will be a number of screening tests will be already present. But we have to see whether it is cost-wise also less or not. But whichever the test we are going to do, it should be less than the previous screening test, so that it will be easy for us to put in action. In general public, we can able to easily put the test. So cost is one of the factors that we have to see. So this is all about the basics about screening tests, how to use screening test, and what is the difference between screening and diagnostic test. What are the criteria that all these things we have seen.